Hello everybody. Today I'll try to talk about the evaluation of combination prevention for HIV, or at least share some insights and some challenges. Preventing HIV could have been simple if we had a fully effective vaccine, but since we don't have that, we have to address the issue by combining different approaches and different steps. And in this slide you could see kind of the summary of how these steps can be classified. We have to reduce transmissibility when somebody is exposed to an infected person, and we have ways to do that. One of the most recent ones is by treating people with antiretrovirals, or male circumcision, for instance, to reduce the chance of a transmission. We have strategies that reduce the exposure to an HIV-infected person, which can be by reducing the number of partners, the types of partners, so anything which has to do with sexual behavior change. And all that has to happen in an environment that is enabled by empowering people, by some norms that have to change, services that have to be available, etc. So that's just as an introduction. And I think we all recognize that even if we have some very good biomedical tools to prevent HIV transmission, that the human behavior is at the center of all of that, because you have to negotiate the condoms, you have to adopt safer sex, you have to accept an HIV test, you have to adhere to antiretroviral treatment, you have to seek care if you want to undergo male circumcision, etc. So that I think is important. And if we then see how UNAIDS now defines combination prevention, it's actually quite a complicated definition, but it's the strategic simultaneous use of different classes of prevention activities, from biomedical, behavior and social, that operates at multiple levels: individual, relationship, community, societal, to respond to the specific needs of particular audiences and modes of transmission, and to make efficient use of resources to prioritizing partnership and engagement of effective communities. So I just show this. This is one of the definitions, but as an introduction to actually conclude that everybody will agree that if we want to prevent HIV, this involves complex interventions. And now to evaluate how a complex intervention, whether a complex intervention works, seems to be more complicated than we initially anticipated. And I think for those who are from the biomedical field, the gold standard for evaluating, for instance, the efficacy of a drug is the randomized controlled trial, RCT, as you see in the title. Sorry for the abbreviation. But what we do know that we have robust evidence based on randomized controlled trials for instance, pre-exposure prophylaxis, giving a pill in advance, or, for instance, for male circumcision. So these are, I'm not going to review this. This is just as a, so for these components, we do have the robust randomized control trial evidence. When it comes to what works in behavior change or community empowerment, for instance, this is a much different story. And especially then, if it is a question of how do we combine the biomedical approaches with the behavioral and the community empowerment approaches, which is the basis of combination HIV prevention, how do we know whether it works? Well, one of the experiences we have had in the past is that by using the approaches of randomized controlled trials, but then community randomized trials for prevention, to evaluate prevention efforts, this has also been applied for combination HIV prevention. There's been several trials that have attempted to measure the effect of a combination package on HIV incidence as an endpoint. And in fact, one of the striking findings, if you put them together, and you see the list of the trials here on the slide, is that none of these combination prevention trials showed an impact on HIV incidence. For all of them, the effect on HIV was flat. Some of them had some effect on, for instance, pregnancy or on STI levels or on knowledge or something, but not on HIV incidence. And that made many people think, what could be, first of all, there's been a lot written on what would be the reason why these combination trials show flat results. And there's been thought about that the control group was not a real control group, was somewhat diluted, so that the intervention was too weak because the trial design led to fit the intervention to the trial in terms of led to have a good, well-defined package, standardized, that then maybe was less effective. There was issue about power, whether there was enough power in these trials, because HIV is a rare event and it takes a long time before, so it's a long and complex pathway also between the intervention and the endpoint. There may have been context specificities or even lower uptake of the intervention. There's been many explanations given for the possible lack of effect of these trials. So one of the big questions raised then is, are these interventions, the way they have been evaluated, the ones that have been evaluated, are they truly ineffective interventions, or is it the evaluation method which is not appropriate to try to measure the effect? And that's one of the things, in fact, the topic of my talk here is a little bit this evidence dilemma we are confronted with when it comes to these complex interventions. Because on one hand, we all agree that we want evidence-based prevention planning. So we want prevention that is based on true evidence. But if we define evidence only as good quality randomized controlled trials, then we limit ourselves, in fact, to interventions with a preferably short impact pathway that will be in the field of HIV prevention, then predominantly biomedical approaches. And that's sometimes when you see a list of evidence-based prevention interventions, it is very often limited to male circumcision, mother-to-child transmission, or antiretroviral treatment. So, since we believe that combination prevention should also include social movements, advocacy, education, social mobilization, together may make the interventions much more powerful, but these are much more impractical. They are less practical to prove the evidence because they have a well-defined, longer, more complex pathway. So maybe the cluster randomized controlled trials may not be the exact or the preferable method. That's the whole discussion. Should cluster randomized controlled trial remain the gold standard for evaluation of combination prevention? I am definitely convinced not, to some extent, because of what I just said, and because then we will be very limited in our interventions that we will be able to prove as effective. And especially because, and I think that's important in public health and in many things, absence of evidence does not mean absence of effectiveness. So we may leave a lot of effective approaches aside because we are not capable of documenting clearly the evidence with the classic approaches. I think especially in HIV prevention, more negative trials not only cost a lot of money, but also add to the confidence crisis in HIV prevention already existing. Maybe there's a new enthusiasm now with treatment as prevention, but for a long time there's been a real crisis and many people really truly doubting whether we are having any effect with prevention and whether prevention works at all. So that brings us to, are there then alternative methods to obtain rigorous evidence? And that's, I'm referring here, you see the title of the paper, that's a paper we wrote together with colleagues from UNAIDS and from the World Bank on exactly asking that question, exactly asking the question, or is the perfect prevention effectiveness, is the perfect the enemy of the good, so the perfect referring here to the cluster randomized trials. If we limit ourselves to that, will we end up with a basket, an empty basket for HIV prevention? So I think there are several steps. There are indeed alternative ways, or at least alternative approaches as long as we are willing to change or change our paradigm a little bit in terms of what we expect, what we understand by rigor or what we understand by evidence. And first of all, I think it's important, and in other fields and in the field of development, people have been much more advanced in it, but in HIV prevention, we have to be willing to deal with the complexity, to simplify the complexity as much as we can, but not become simplistic. But at the same time, it is true that we have to be willing to recognize that this is complex, much more complex than a pill or a male circumcision by itself, but that we have to disentangle the complexity by using theories of change and program theories and logics. So spelling out the different steps makes the connection explicit. And here it is clearly recognized by many people who work in the field of HIV prevention that too often the work invested in trying to understand the components of a prevention approach has been often limited, and people agree quite quickly on this is a package of, these are the components and that we want to evaluate, and do not fully or better try to understand what is the interaction between certain aspects of the context and the way, why and how certain mechanisms will work or will not work in certain circumstances. This is just an example of program logic from the development field, but just to see that in fact these things have been around for quite a while in other fields, and it's in HIV prevention and in especially as a tool, not just for designing better interventions, but also to have a framework for evaluation, that we are in fact discovering them now, more recently. Then there's another issue. There's the issue of how sure do we want to be when we show effectiveness. And Habicht made this very clear in a paper a while ago on the levels of evidence and public health from probability, plausibility and adequacy. And we tend to believe that we have to have an evidence at a probable level, highly probable level, 95% confidence that the effect is caused by the program or by the intervention. And that is the case when you evaluate a drug or when you evaluate a highly controversial intervention such as male circumcision. But when it comes to a package of intervention, it may well be that we are satisfied and that it's more than enough to understand that there is that we build a plausible case, that this package of intervention in this context is likely to have had the effect that we see, for instance. And then we don't need to randomize, but we can have a comparison group, a control group, based on historical, external, internal, or even simulated and modeled way. So when we talk now, so that's the other point, we have to lower our expectation when it comes to probability. When we talk about plausible attribution, then what are kind of the methods that we can use? And here you see a list. I think some of the keywords in these approaches are triangulation of different data sources, surveys, routine data, surveillance, program data, and context data. And that implies that the methods are mixed, quantitative data to set a framework and to be are essential, but in addition, a set of very good qualitative data to understand mechanisms of which or why certain things happen in certain contexts are extremely essential. It's important to take into account the causality considerations, the old Bradford-Hill criteria, some of them just, it's in a way a lot of common sense reasoning here. Did the intervention temporally happen before the outcome came? Is there a dose relationship, etc., etc.? So you know the Bradford-Hill criteria. I'm not going to repeat them. And I think one of the more recent, I would say, evolutions is that modelers have become much more sophisticated in helping us with the absence of a counterfactual, so to speak, and that through modeling, simulated control groups can be created and can be predicted in such a way. when we now ask the question, and how do we obtain evidence on HIV prevention, I think there are two approaches that have shown to be successful, and one is working backwards, is trying to understand why some successes have happened, and that is mainly making sense of national trends and showing effectiveness on ongoing real-life programs when they have already happened, versus prospective evaluation. That means planning to evaluate a new program that has to be set up, or a new approach that will be ongoing. On the first part, on working backwards, I think there is really a new and encouraging trend in HIV. We've been seeing that there's been a lot of declining trends that have been observed in, for instance, in many African countries, but in fact in many places in the world. And it's important to, first of all, what do these trends mean? Because very often, as you see here on the slide, this is from Kenya and Ethiopia, older data, but these are declines in prevalence. We now know that declines in prevalence do not necessarily reflect declines in incidence. That may well be a balance between declines in new infections and increase in mortality, for instance, or migration or other factors that could interfere. So it is important to first really analyze the epidemic trends, make sense of them, and also here there's been a really encouraging evolution of, again, modelers who have helped to understand, for instance, what you see here is that the national trends of HIV incidence. This is modeled HIV incidence based on prevalence data, and to see actually which trends decline is just a result of, I would say, natural decline of incidence as a result of saturation and spread in a community, and what is accelerated, for instance, be due to behavioral change. And this is, for instance, the example of Zimbabwe, where it has been clearly shown that between 2000 and 2010, there's been a clear accelerated decline in HIV incidence, and then it's very important to know how and why has that happened, because that can teach us also a lot, and we should make sure that we make maximum use of this. And there's been a whole working group and several research groups together with people from the national program in Zimbabwe have really tried to deconstruct the whole story of HIV declining incidence, and have been able to make a plausible case. So they work backwards. So they first look at the declining incidence. Is there evidence that there has been behavior change? Or is it due to emigration, or is it due to increased mortality? Then there was enough, with confidence, could be said that there is clearly a behavioral change component. Then the question was, how is this behavioral change component? What data sources show that? Partner reduction, abstinence, more condom use, and then what programs could be linked to this change in behavior, and what are other factors that would personally explain that. And so there's been a set of working backwards work, both quantitative research, focus group discussions, and trying to understand. And this is a long, and there's been several papers published on that for those who are interested. But in fact, it was interesting to see that, at least in the Zimbabwe case, reduction in number of partners, reduction in going and in sex work, high levels of condom use are definitely factors that explain the decline in HIV incidence. Qualitative data showed that there was also a change in norms, and also the intense experience of high mortality in the late 90s, in the mid and late 90s, worked for quite a while as resulted in behavior change in individuals. So this is just an example to illustrate this working backwards. That's another ecological example of increased ART coverage, which leads to decreased probability of acquiring HIV. So it is not a randomized method, but it's using quantitative data mainly here to actually make the case of that antiretroviral treatment, in this case here, reduces HIV acquisition. I think a well-known example to finish is the evaluation of Avahan. Avahan is a large Indian HIV prevention program addressing several key populations, female sex workers, men having sex with men, and intravenous drug users. The idea was here, when the program was set up, to use a prospective impact evaluation using a plausibility design. The initial phase was to make sure that all the program implementation data were collected. So it was what are the towns covered, the peer educators, the groups covered, the condoms distributed. So these are the the process documents well the process. And as you can see, for those who are not familiar with this program, this is a very large program in the southern states of India, the most affected states of India in terms of HIV, where in 200,000 female sex workers, about 70,000 men having sex with men, and about 20,000 drug users were reached. Here you see the evaluation design, in fact, which was a combination of, again, in addition to measuring the implementation of the program, the evaluation was based on a series of cross-sectional surveys, integrated behavioral biologic assessments, and then analysis of the trends of these surveys, and using then modeling to illustrate the impact of so the whole, as you see here, the logic of the question, to some extent they have made a simplified, or they have at least disentangled somewhat the complexity of they have asked the questions, first of all, have we implemented the intervention properly? That's the first blue box with the questions. Then what have been the epidemic outcomes in terms of condom use, in terms of reduction in STI, in terms of reduction in HIV? And then the question, to what extent has Avahan contributed to these changes? And the data, there are about 200 papers now published on this. It's now one of the best documented HIV prevention programs in the world, but I think the only paper I show here is one of the most recently published papers, is one of the final analysis of impact of Avahan, by showing that using, in fact, a causal pathway modeling analysis, as the title says, and they showed that the program has averted up to 600,000 HIV infections in the last 2 years. That was based on all the intermediate steps that you saw before. I would say it's an encouraging example, and it's a bit of a Rolls-Royce evaluation, because it's really a very sophisticated evaluation, but which is convincing, shows convincingly that such a large combination prevention program has worked. So in fact, to sum up, I think as a conclusion for this seminar, I want to say that it's very important that we redefine the meaning of the question, what works in prevention? And that if we will solely depend our evidence-based HIV prevention planning solely on randomized controlled trial evidence, that will not only limit our options very much, but we may not be capable of we will miss out a lot of the potentially intervention approaches, and we will leave them out because the evidence cannot be proven through that method. So we have to lower our expectation when it comes to probability evidence. When and why precise estimates of impact are needed can be discussed, but it is clear that for these packages of complex combination prevention, it is as important to know when and why they work than whether they work. But the whether, if we have a precision of around, let's say, 60 to 80%, this may be well enough, and the additional questions may help us to tell a much more meaningful story in terms of, and be much more helpful for HIV prevention programming. So we should also learn much more from national program successes and from real-time program evaluation. As programs go along, we have to learn while doing, and not just only focus on the prospective evaluation. And because of that, because of what I just said, there is a clear need for a much stronger collaboration and cross-fertilization between academic researchers, evaluators, and program implementers, because these worlds are often too separated, and therefore we don't get enough out of the real world, and we keep functioning in two separate realities.
So to begin with, I want to share a question from Sindra Foy, whose name I'm sure to be mispronouncing. And this was fairly early on in your presentation, Dr. Laga. You said something about, speaking about combination trials, and he would like to know if the interventions had been proven to work individually before failing in the combo trials.
Well, that's a very good question, and I'm not sure if some of the individual components were evaluated. For instance, many of the trials included somehow the promotion of condoms, and for condoms, well, that's a bit of a special issue, because condoms have never been evaluated in randomized trials, mainly because of ethical reasons. They have been assumed that if you use them correctly, that they work. Epidemiologic evidence has, though, shown that populations who use more condoms, at least in controlled settings, that the transmission of HIV is reduced. But to come back to you, for instance, some of the trials were trials on interventions among young people, and there some components were evaluated, or there was evidence. For instance, if you treat an STI, there is biologic evidence that you reduce the transmissibility of HIV, at least at an individual level. An individual with an STI and HIV will be less infectious to his partner. So there were definitely components of the complex intervention that were for which there was some evidence. For many others, I think there wasn't. But in my reading of the intervention, and I wasn't involved of any of these trials, is that really well-defined, standardized packages. They weren't the very large, I would say, community-driven combination packages as we would expect them. And that's a little bit the dilemma that is these trials are putting on because such trials, in fact, require quite defined packages, because you have to randomize groups to the package and other groups to the control. So that means that, and that's what some critics say, that you end up having the design, your evaluation design driving your intervention, which of course is paradoxical, and we shouldn't. I think the intervention should not be driven in the first place by your evaluation method. But that has been one of the dilemmas.
One more question from Laurie Heisey, saying how others in the HIV field have responded so far to your advocacy for moving towards plausibility as the metric for evaluating effectiveness. Who's been the most receptive and who is resistant? I think it's a really interesting question for those of us who are trying to advance this kind of communication.
The discussion about yes or no randomized controlled trials is always a very emotional, and it's never a very neutral discussion. I must say I discovered that myself in the last years. I didn't know there was still that much emotions around it. I think the world remains very divided. I cannot say that everybody applauded, and there is, on one hand, people who really favor and randomized approaches and probability evidence as the way of doing it, and believe that even in the more complex interventions this can still be done, and that randomization is always the purest way of trying to show program impact. On the other hand, I think there's been a lot of realism that has come into the thinking, and because of the recognition that we end up with such an empty toolbox, because apart from some biomedical interventions, and maybe one trial on cash transfer, but then others don't. There's been a recognition that we may understand the interventions much better, and that it may be much more rich to have a better insight in the whether and the how and the why, and giving in on levels of probability is not such a bad thing then. So let's say I feel, if I say myself how I'm exposed and what reactions I get, and when I give these kind of presentations, I feel an increasing sympathy towards this point of view, but having said that, there is still resistance by some people who say that we can only talk about evidence-based interventions when they are proven by randomized approaches.